I'm audible, right?
Yes, sir.
Share the screen. Able to see the screen?
Yes, sir.
Okay, so we'll just refresh on the section 2, the principal diagnosis. Okay, so this is mainly focusing on, this section is mainly focusing on in what scenarios and in what situation and in what circumstance we should consider the principal diagnosis. That is what the main concept of this entire section. Okay, so on the base of first we were discussing on codes for symptoms, signs, and ill-defined conditions, right? So in this, as we discussed in the chapter writing, what is the slight difference there and here? So we already know sign is something where I can able to see by naked eyes, which will be objective, and symptoms will be which I should be tell by my own mouth, that will be subjective. Okay, so in this basis here, when it comes for a principal diagnosis, okay, the signs and symptoms should not be taken as a priority or shouldn't be coded when there is a principal diagnosis, since entire inpatient or entire principal diagnosis concepts work based on the principal diagnosis. Always remember the definitive diagnosis which is proved, that will be considered as a principal diagnosis, not the signs and symptom. Okay. The second thing we were discussing on, two or more related, interrelated conditions, each potentially meeting the definition for the principal diagnosis. So there will be a conditions where you may get one more than one conditions. In that situation, you should be taking both of the conditions. Okay, since the both are interrelated conditions, and the treatments or the procedure, whichever are the services, whichever going to be provided, is going to be for the both the conditions. In that situation, especially interrelated condition, in that situation, both need to be considered as the principal diagnosis. Okay, so as I told, POA, present on admission, that as an indicator, where the indicator will indicate with Y for the both CHF and pneumonia if the both are interrelated conditions. So I will be detailing you on POA when we are discussing about the separate slides and separate topic on the POA. And the second thing is like, third thing is like two or more diagnoses that are equally met the definition for the principal diagnosis. Okay, here, so there at least we had a chance where I can go with anyone, but here I do not have any chance because equally they meet the principal diagnosis, where I should consider both as the principal diagnosis. Where I can possibly make the changes means with the help of DRG, that is diagnostic related group, which has the higher hierarchy group, that condition need to be considered as the primary or principal diagnosis. Okay, that is what I'm trying to tell here. Then fourth thing is like two or more comparative or contrast conditions. So if you see, this seems to be both the conditions are seems to be relatively or contrastingly both are important. Okay, these both conditions are very much mandatorily important. But other signs and symptoms, okay, other signs and symptoms and the procedures and the services were focused on either in appendix or diverticulitis. So based on that, we will be concluding the principal diagnosis. Okay, if you see both appendicitis and diverticulitis and cholecystitis and pancreatitis, which do have the equal importance. But the scenario or the service, if it is supporting for pancreatitis, I'll be going with the pancreatitis. Or if it is supporting for appendicitis, I'll be going for the appendicitis. So it is like we need to know the pathophysiology of the condition and features of the conditions. If you know the features of the conditions and we can tell like clinical indicators. That will be one more topic we'll be discussing on clinical indicator also. The right time, right term to use in the especially in the IPDRG when you are encountering for the principal diagnosis. In these situations where the conditions are equally contrasting and comparative diagnosis, both are very important. In that situation where I need to follow the clinical indicators. So whichever the condition is for, whichever the condition is supporting, whichever the documentation is supporting for the particular condition, that will be considered as a principal diagnosis. That is what we're discussing in the previous class. So here we had two example, appendicitis and diverticulitis, cholecystitis and pancreatitis, where in the beginning with the first one, we had an example and the documentation supporting for the appendicitis. So there the appendicitis may be considered as a primary. And second here, cholecystitis and pancreatitis, here the documentation is entirely supporting for pancreatitis, where pancreatitis can be considered as the primary conditions. Are again, primary principal diagnosis. Then Original treatment plan not carried out. Okay, there will be a situation, even this we were discussing in the previously. So with the example I was talking about. So here, where there will be a situation, so the originally they will be planning for some procedures or some treatment, but that will be not considered. That will not be completely taken care, and that will not be carried completely. In the situation, we'll be indicating with two important categories of ICDs, that is Z53, and one more is Z91.1. Okay, these are the two important categories of code which are very widely, very mostly used when the patient is coming for some treatment or some service and it is not completely performed or it is not carried out fully. In that situation, I need to indicate with the we can tell, like we can indicate, we should be indicate with the secondary DX. Primary, it should be the condition, which means the principal diagnosis whichever is coming for, followed by that we should be using. So that is what we have seen some examples here. If you see one example, we have seen for the equipment failure prevented the surgery. So there we saw like for the patient cesarean section, they count that will be the principal diagnosis, and since it is not carried out, Z53 was considered as the secondary set of example, which means secondary diagnosis for the first scenario. And if you see the second scenario, here also they were finding for the admitted for the hyperglycemic crisis due to underdosing. Here what happened? Here the diabetic patient with the severe hyperglycemic, social history reveals financial hardship. Lab indicates patient has only the intention to take less insulin. So here the Z91 is indicating that whichever the patient is not able to provide enough, or we can tell financially is not fit to take the complete treatment in that situation. So where I'm not able to provide, which means I'm not able to carry out the complete treatment for the patient. So in that scenario, I will be indicating the principal diagnosis as a diabetic with the hyperglycemia. Since the insulin level, whichever the recommended level was not taken by the patient due to his social hardship or financial hardship, we need to indicate with the second category of ICD, which is like pattern non-adherent to the treatment ratio. So first one, the category is like acute non-performance of the scheduled procedure. So that says very clearly, whichever is planned, it is not performed. Second is like whichever the treatment need to be provided, it is not provided. So we have the two categories of code which will be code along with the principal diagnosis. Then we have the next one, complication of the surgery and other medical care. So here, so after the surgery, especially after the surgery, if you get any set of complications, okay, that need to be considered as a medical care. We cannot again do a separate payment or separate reimbursement for whatever the post-operative condition, infections or complications. Okay, so here that is what I'm trying to tell. So they have done the central line infusion. In that situation, we need to call the complication followed by the what is it? We need to go with the sepsis. Then we need to go with the severe sepsis code. Then finally, if any failure, any organ failure, something is there, that need to be considered. Mostly, I don't think so. Organ failures and all will come for this kind of situation. We need to mitigate with the complication followed by the whatever the conditions here come for, or the principal diagnosis CS come for will be the priority. Then we entered into the uncertain diagnosis. Okay, when it comes for the uncertain diagnosis, there are few rules set for both inpatient and outpatient. Okay, so there is a slight difference when it comes for the uncertain diagnosis. So that we'll be further discussing. So this particular different what is it, a coding rule for the section 3. So in the section 3, we'll be discussing little more on this uncertain diagnosis that I will be elaborating there. And here they're trying to find certain conditions, certain terms, conditions with certain terms which should not be considered for the outpatient. There are the terms which will be prefixing along with any conditions can be considered in few instances. So if you see, if the documentation at the time of discharge is qualified as probable, suspected, likely, questionable, possible, to be ruled out, compatible with, consistent with, or other similar, indicating uncertain code condition as if it exists was established. See here, we do follow UDHH. Okay, UDHHS rule. Okay, what the rule is like, discharge rule, we can call it as. So during the discharge, see the main aim of this entire IPDS is like, after doing some diagnosis, you've been admitted, which means you became the inpatient, you've been converted to the inpatient to treat the patient. Now, when I'm getting discharged, it is not mandatory you are going to have that condition. Okay, you are not going to have that condition mandatory, because for that only you got admitted, for that only it is got treated. So when you're getting discharged, These conditions, or say for example, cirrhosis or kidney stones, okay, whatever the conditions after treatment, they may not be existing in your body. They may not existing with you. In that situation, I may indicate completely it is relieved or completely it is treated or completely it is removed or it is suspected or likely to be or questioned to be, which means like you became an inpatient for by diagnosing some condition. After the proper treatment or after the proper service, that may disappear. In that situation, I may use this uncertain diagnosis terms, which will be indicating in inpatient, we should be considering that. Okay, we should be considering the inpatient. But when you see same in the outpatient, you cannot consider these terms. Okay, especially the suspected, likely, questionable, probable, rule out. You cannot at any cost. You cannot consider these conditions. Again, one more small difference we used to encounter when you are doing IPDRG. This ruled out and ruled out. Ruled out, which is something like the patient had and it is completely removed. That is ruled out, past tense. Okay, that is what it is indicating to you. But when it comes for rule out means they're going to find. Okay, that will become the present tense. Okay, that will become present tense or future tense. Either I need to find it or I have come to find something. That is what rule out. In IPDRG, this one term, often they use it in the documentation, especially in the discharge summary, where physician use like their dialect and their what is it their language is that form. Okay, so it is like very often they use this term ruled out and rule out. Rule out, so we say right is completely treated. The condition is completely treated. That is what ruled out. It's treated. That is what they use the term. When we say rule out, we need to find. We need to find whether the condition is there or not, future or present. So but if you go for outpatient, yes, rule out has the same rule there also. But when it comes for ruled out, mostly it will not come in the indication because nobody is going to come for the treated or which has been treated already. You are not going to come for the diagnosis there. Okay, so in that scenario, that ruled out term won't be there. So very simply, if I wanted to conclude, uncertain diagnosis where in outpatient these terms cannot be considered, but in inpatient we can consider these terms. Okay, then admission from the observation unit. Admission from the observation unit, it is mainly two things are there. Okay, so first thing, admission following the medical observation. So when they came to know, they have found some problem in you. Okay, when they're doing the diagnosis, when you're coming as outpatient and they came to know you have some problem which need to be treated, it is severe or something, it is very emergency, which need to be treated immediately, where you will be converted to the inpatient in the same hospital. Okay, so when you got admitted to the hospital, what is the reason? What is the indicator or what is the reason or what severity or why you are made to admit in the hospital? That particular condition will be considered as the principal diagnosis. So you come for the observation. Okay, you come for the observation. Like usually you might have come for observation, but doctor felt no, you have to get admitted. We need to treat you. Otherwise, that will become an adverse. Okay, so in that situation, we have to go with the principal diagnosis, which will be the reason for the admission. Then post-operative observation, admission. So this is something, it is like after the operation, okay, after the operation, which means especially this happens when you have become a surgery patient, especially in the outpatient. Okay, we do have the specialty surgery. In surgery, we call it as ambulatory surgery coding. Otherwise, one more set of coding is there, same day coding. Okay, we call it as SDS. Here, usually, if you see, this will be like we may feel those are major procedures in our country. Say, for example, in surgery, like if they're going to do the replacement, okay, arthroplasty replacement or some arthrodesis they're going to do, or if they're going to do any excision or they're going to perform any scopy. See, these are some kind of procedures in our country where they ask us to stay for more than 24 hours. Okay, based on that only the payment will be paid in our country. But in their country, they need to go within 24 hours because after 24 hours, the charges are going to be more. So even if they do knee arthroplasty or any major procedures also, major in the sense electively, see, when it comes for the procedures, minor, major, and in major again electively or selectively, different set of procedures are there. When it comes for selective or elective procedures, it is something like we need to get admitted, we should become the inpatient for the long term. But Even it is a major procedures also. See, even they will remove the gallbladder, they put a cholecystectomy, they do the cholecystectomy by colonoscopy, sorry, laparoscopy, they put in a hole and they will remove the gallbladder by morning, then by evening they will send. That is why it is called same day surgery. Okay, now when the patient wanted to discharge, during the discharge, their discharge summary or the discharge things are not justifying, which means the patient may encounter with patient may end up with the complications. So it is better to admit the patient. It is better to admit the patient. So and the outpatient who come for the same day surgery, I've been done with the surgery, but what is happening there? I may encounter some complication or I may not fit to get discharged. Then I become the inpatient. So that is a scenario they're telling that will be considered as a principal diagnosis. Okay. So here, code the condition chiefly responsible for the admission as the principal diagnosis. So the reason I came for is removing the gallstone. Okay. After removing the gallstone, maybe there is no bleeding stopping inside my stomach in the abdomen cavity. Now I need to get admitted. When I get admitted, here the principal diagnosis is the bleeding. It's not cholecystectomy. It's not gallstone. Okay. The complication, whichever the complication is laid after the operation, need to be considered as a principal diagnosis. That is what they're trying to tell you this paragraph. Admission for the outpatient surgery. Okay. Here, say for example, so the reason for outpatient surgery coded as a secondary diagnosis. Okay. So here what they're trying to tell, the patient, he may come for have the primary surgery. Say for example, we'll take the same example, like they may ask them to come for the cholelithiasis. The patient may be having the cholelithiasis and they may be asked you to come for the surgery. Okay. So now automatically what happens when they ask you to come for the surgery, they may feel there will be a complication. See, the small difference between the previous one, this one is like that is after the surgery, this is going to be before the surgery itself. So you come for the surgery for the outpatient, but they are made into the inpatient because you may end up with the post-surgical complication. It is like predicting or assuming before you may end up with some complication. It is better to admit it. There you become inpatient. Now the principal diagnosis is going to be the reason, whichever the condition, whichever responsible or whichever it is leading to make you to admit in the hospital, that will become the principal diagnosis. Okay, that is what here also an example they provided. Okay, principal diagnosis vomiting and cholelithiasis and the surgery reason will be secondary. Okay, so patient has an outpatient cholecystectomy, then develops intractable vomiting requiring admission. Okay, so here completely the patient who had an surgery one side and he is end up with the vomiting, there the vomiting becomes the principal diagnosis. Okay, then next thing is like admission encounter for the rehabilitation. Okay, so admission encounter for the rehabilitation. Here, so the patient might have taken some, say for example, fixation, especially if you see like this hip replacement or knee replacement. Okay, so that if the patient is already taken the surgery, okay, for some fracture or something else, or any other fixation like arthrodesis, okay, or any what to tell, any surgery, okay, after completing that they may ask you to leave, right? Then later cases you have to come back. Okay, you have to come back for the same. Okay, now so we can tell like this, use this codes when the initial condition has been treated are no longer existing, but the patient requires therapy to return to the function. Okay, so especially this surgery, we can tell like rehabilitation. I think you understood what is rehabilitation. Rehabilitation is like something recovery phase, we call it as rehabilitation. Okay, from the current injury you may encounter some kind of treatment. After the treatment you may ask to come for the follow-up. Okay, when you're coming for the follow, there you may ask to admitted for doing that follow-up, because the whatever the treatment they provided, for that they need to make sure okay it is completely cured, to ensure it is completely treated. Okay, for that it may take some time, or it may take some even it may take hours, like it may take 1 or 2 days also to ensure the patient is completely okay. So during that situation, okay, the reason for admitted here is like the follow-up, the rehabilitation is the reason for admit. So in that situation, the rehabilitation should be coded as a principal diagnosis. Okay, see here the subsequent encoder is considered as the principal diagnosis, not the initial encounter. If you see for the knee arthroplasty and all, same, it is fixed. Now you are completely okay. So now after 1 or 2 months, like after 1 or 2 years, you will come back to remove the rod. You wanted to remove the rod, or you wanted to remove the plate, or you wanted to remove the stitches, something like that. Now you get admitted. Okay, so it may take more than 1 or 2 days. That will be considered as principal diagnosis. So the reason here is like, say for example, a patient, orthopedic patient, like they wanted to replace the bolt or they want to replace the net. That is the reason you got admitted. So that will become the principal diagnosis. Then whatever the condition he has come for, that will become the diagnosis. Even symptoms also here, it will become the secondary diagnosis. Okay, so that is the main thing here for admission encounter for the rehabilitation in the section 2. Then we are coming for the section 3, where it tells reporting additional diagnosis. Okay, it is a small chapter, so it will indicate how to report the additional diagnosis. Okay, so we have three things here: previous condition, abnormal finding, and uncertain diagnosis. Okay, so this majorly these guidelines, okay, address how to report the additional or secondary diagnosis in inpatient settings such as hospital, long-term care, and the psychiatric hospital. Okay, this section applies inpatient admission and defines the criteria and exception for which condition must be coded beyond the principal diagnosis. What they're trying to tell you here, it is not only like if you're becoming the inpatient, it is not only like you should be coding one ICD, which means it is not like you need to go into code only the principal diagnosis. You can code the secondary diagnosis also, which means additional diagnosis also you can code. Okay, so in what situation you code, what are the scenarios will get qualified for that? Okay, see here, additional diagnosis qualifying for coding in the requirement one or more following: clinical evaluation of the condition, therapeutic treatment for the condition, diagnostic procedure to evaluate the condition, extend the length of the hospital stay as the result of the condition, increased nursing care or monitoring due to the condition. Now, if say for example, see here they categorized the three: previous condition, abnormal findings, and uncertain diagnosis. When it comes for the previous conditions, okay, so it is like we can tell example, see code condition including in the discharge summary if the persistent to current state. Okay, so previously I was admitted for cholelithiasis, okay, to removal of the gallstone. Okay, during the discharge I may encounter I had some other condition, say for example pancreatitis, or I had a cirrhosis. Now the reason I got admitted is cholelithiasis, but my stay is getting extended. My stay is getting extended because of some condition, some new condition they have found. Okay, some current condition they identified now, so I need to stay for some more time. Okay, that is one scenario. Okay, so if you see here, extending length of the hospital stay as a result of the condition. Okay, so we cannot take that point. We can take a clinical evaluation of the condition, therapeutic treatment for the condition, diagnosis procedure to evaluate the condition, increase nurse care monitoring during the condition. So we can take clinical evaluation of the condition. Yes, that can be considered. Okay, because extending the length of the hospital stay as a result of the condition means for the same condition, if they're going to extend their time period, in that situation also, yes, that will be considered as a principal diagnosis, and that can be become a second additional diagnosis also. Same conditions can become a additional diagnosis because they are the reason for the stay for the hospital. Okay, here what example I was telling about is one condition is already there and that is completely cured, but when I'm getting discharged, I found one more condition, still I will continue my stay. Okay, that is one scenario. Then second stage is like abnormal findings. Yes, so I came for some to treat something. Say for example, they have come to treat the kidney stone, will remember. Okay, stone in the kidney. So now they're giving the treatment. After giving the treatment, you may end up with the inflammations, or you may end up with the other infections in the bladder, okay, like UTI, because they're treating your kidney stones, they're removing your kidney stones with different methods, where it will end up with the infection. Now what happens? There is one more abnormality, which is asking me to stay for some more time. Okay, that is what abnormal findings. So I'm treating something because of that, or even during the hospitalization, I get some abnormality that will become a significant reason for becoming the inpatient. Then uncertain diagnosis. Okay, so uncertain diagnosis patients on inpatient discharge are coded as if they exist. Okay, so here uncertain diagnosis means, so we discussed already, right? In uncertain diagnosis, those terms we have discussed. Now some conditions, so I have come to treat some condition, but some conditions they may end up with the uncertain diagnosis. Okay, which means they suspected for say for example suspected for anemia. I'm a cancer patient admitted for in the hospital. I have given the chemotherapy for some days. Now, after giving the chemotherapy, I'm ending up with anemia. Okay, I am ending up with anemia, which is not confirmed, which is not completely proved. Now, during the discharge, they may tell you patient is treated with the cancer with the chemotherapy, possible for anemia. What they may tell? Possible for anemia. When they tell possible for anemia, in that situation, what I'm supposed to do is I need to consider the anemia also. Okay, I need to consider the anemia as a additional diagnosis. That is what they're trying to tell in the uncertain diagnosis. Okay, this is what the overall picture on the section 3. So mainly they're focusing previous condition, abnormal findings, and uncertain diagnosis. For inpatient, we can tell it is a non-outpatient guidelines, or we can tell it is an inpatient guidelines. Okay. Then section 4. Okay. Just give me a minute.
Yes, sir.
Okay. So the foremost, the last now section in the entire ICD chapter, that is section 4, diagnostic coding and reporting guidelines for outpatient services. Okay. So here, these all are related to the outpatients. So the first section, which has been uh, conventions, general guidelines, and chapter specific guidelines, which is applicable for both inpatient and outpatient. When it comes for the second section and third section, desperately they're going to support for the inpatient coding. Okay, when it comes for the fourth section, it is going to support for the outpatient coding. Okay, the first thing is like selection of first listed condition. Selection of first listed condition. So outpatient surgery observation stay. See what I'm trying to tell in this particular chapter. So the condition, okay, the condition whichever is proved in the impression will become the first listed condition. Okay, will become the first listed condition. Say, for example, we'll take a simple example. A patient is coming for abdominal pain. When the patient is coming for the abdominal pain, now the impression is proved with 4 conditions: diverticulitis, pancreatitis, gallbladder stone, and kidney stone. Now, which is going to be the first condition, or which is going to be the primary diagnosis? Here, this is outpatient. The term is going to get to use primary diagnosis. The principal diagnosis means the condition is responsible for the admission is called as a principal diagnosis. Okay. And the condition whichever is proved in the documentation, which will be considered as a primary diagnosis. Okay, primary diagnosis means something I need to identify. Identified condition and you got admitted, that will become the principal diagnosis. Okay, so here, primary diagnosis, what will be the primary diagnosis? I have 4 important conditions. See, if they're told right upper quadrant pain means I will go with the, I can go with where gallstones I can go. Okay, but they are told generally abdominal pain. Okay, it is like when they tell abdominal pain, I can consider that as I can assume something like the pain in overall the abdomen. Right now, the patient is having 4 different conditions, proved conditions here. Okay, now what I'm supposed to do, which need to be coded primary, which I need to consider as a primary. Now, in the impression, whichever the physician is documenting as the first listed or in the first sentence or first line, whatever the condition is talking about, that need to be coded as a primary diagnosis. Yeah, say for example, the patient is coming for same abdominal pain. Now I will give small, like conditions, relatively very small conditions. One condition is hernia, ventral hernia. The other 3 conditions are inflammations. Okay, like pancreatitis or diverticulitis or appendicitis. Okay, like inflammation. These are very severe. But doctor, the physician who is documenting ventral hernia in the first line of the impression. Okay, he is listing that in the first line. Then that will become the first listed condition. I can consider pancreatitis, diverticulitis, and other conditions as a secondary tertiary codes. Okay, so that is what this entire chapter for both outpatient surgery or observation stay are giving as the meaning. Okay, for the outpatient stay, whichever the physician is listing in the first, whichever is the reason for the diagnosis for as a first, that will be considered as a first listed condition. Same way here, the second point is like, so the codes, okay, the codes we need to be coded from the primary. All the codes need to be considered from the, what is that? Section A to section T through section 3, then section Z and section Z99 and U00, U85. Same like how we saw in the general guidelines, same way here also for inpatient, for outpatient, we need to consider the codes from this section. Nothing else they're telling here. Okay. Then the next thing is like accurate reporting of ICD-10 diagnosis codes. Accurate reporting of diagnosis codes. Here, if you see, sorry. Here, if you see, I provided some example here, okay, how the inpatient approach and outpatient approach, okay. Rule out of pneumonia, suspected pneumonia can be coded in the inpatient. When it comes for the outpatient, I cannot code the pneumonia. I need to go with the symptoms. Probable appendicitis in inpatient, I consider that as an appendicitis, but in outpatient, I'm going to code it as an abdominal pain. Then suspected diabetes, here I'm considering that as a diabetes in the inpatient. See directly how much difference is there. When it comes for the outpatient, I cannot consider as a diabetes because the glucose level is abnormal. It is not yet proved. Okay, the glucose level is abnormal. That is why they're telling suspected for diabetes lab work. Okay, in that situation, I need to go with the RCS. Okay, here that is what I'm trying to tell with the accurate reporting system. Okay, which when it comes for the outpatient, unless or until it is proved, okay, by using the uncertain diagnosis terms, we cannot consider. Okay, we cannot consider the condition. But if you see in the inpatient, based on uncertain words like suspected, probable, by using these terms, we are considering the we are considering in the inpatient. But same if you see it is vice versa. So that is why they're stressing we need to go with the accurate reporting, which means whichever is proved in the documentation only can be coded. Otherwise, we need to go with the signs and symptoms. Okay, that is what accurate reporting. Then the next one in the section 4D, that is coded describe signs and symptoms. Here very simple what they're trying to tell. So as I told, if nothing is proved in the documentation, just code the signs and symptoms. We no need to be worried. Okay, if condition is proved, just code the condition. Okay, whatever diagnosis is proved, that can be coded. There also we saw like related conditions and unrelated conditions. If it is related conditions, yes, I don't want to code symptoms and sign. If unrelated conditions, code the condition followed by signs and symptoms. That is what the guideline says for the outpatient. Encounter for the circumstance other than the disease or injury. Here, that is the point. Here, see, I have provided some example here. Level of detailed specificity. Okay, come here. Okay. Okay. So let me go with, I think the point is missing here. I have added here. Okay, fine. So encounter for the circumstance other than the disease or injury. So here what they're trying to tell you here means in this particular scenario, see if the patient is coming for directly, say for example, is coming for trauma, or if he is coming for any disease condition, say for example, history is given as we can consider something like any condition. We will just imagine like pneumonia. Okay, the patient is coming for pneumonia. In the impression, they're telling no pneumonia or normal lungs. The finding is normal. In that situation, what I'm supposed to do here, I cannot code the pneumonia. I should be coding Z03.89. Okay, but the same condition, in the same scenario, same patient is coming for pneumonia, and the impression they are talking about consolidations or they're talking about infiltrate. During this situation, we can consider this pneumonia. Why? Because when you get pneumonia, you may get other abnormalities like infiltrate or consolidation. These are the other abnormalities which you'll get because of pneumonia. Not only like pneumonia, if it is pneumothorax or emphysema, mostly like, especially when you have the pneumonia, you'll end up with the consolidation. But these are all conditions you can relate to the infiltrate. Now, in the impression, they are not clearly telling. They're not clearly telling it is pneumonia. Still, because of other abnormality, I can consider pneumonia. Okay, that is the example on the disease. When it comes for the injury, a patient has come for the head injury. Okay, a patient is coming for the head injury. When he's coming for the head injury, in that situation, if conditions related to the injury is proved, okay, like hemorrhage, subcarotid hemorrhage, or subdural hemorrhage, or contusion in the skull, okay, which all are related to the injury. If it is proved, I'm going to code that. If it is not proved, say for example, patient is coming for head injury, but they're talking about some other conditions. If they're talking about some other conditions, okay, in that situation, I will go with the injury code directly. I will not use any other condition proved in the documentation. Okay, that is what they're trying to tell with this encounter for the circumstance other than the disease or the injury. Okay, then level of detail in the coding. Level of detail in the coding means they're nothing they're telling. So we need to take the specific ICD. So if you remember, we were studying in the conventions, we are talking about the third character, fourth character, fifth character. Okay, that is what they're talking about the specificity. So some codes they will end up with the 3 decimal, some codes they end up with the 4 character. Okay, so we need to identify till specific character, where it is ending with the 4th character or 5th character, 6th or 7th character. According to that, we need to code the ICDs. That is what I'm trying to tell you. Then use of full number character repeat for coding same. There is nothing a big difference here. So we need to ensure we are coding complete. That is what examples I provided. Okay, since you are an experienced people, hope you were able to understand that how much the specificity of the coding is important. The 5th character for 4th and 5th character is important. Okay, in the same way, how much of number of character is ending up with that we need to, without fail, we have to code. We shouldn't consider like, okay, placeholder cannot be considered, or something like, okay, 5th character is not very much mandatory, or 6th character is not very much mandatory. We cannot assume like that. Specificity is very, very important. That is what we call it as level of detailing in the coding. Okay, then high specificity coding. If you see that a high specificity, okay, came to this slide. So if you can come for the high level of specificity, again, so when you get in conditions, when you get a conditions, different set of condition, in that we need to give priority for the specificities. Even the hierarchy I told you already. Specificity, when come for the specificity, specific condition followed by the other condition, then followed by the unspecific condition. So these are the, so coding all the characters, complete numbers coding, and high specificity ICD coded as a primary diagnosis. These are all very, very important in the outpatient. Okay, then ICD CM code for diagnosis conditions and problem. Okay, so here, if you see, the first thing is like, okay, the first thing is like diagnostic services only. So when the patient comes slowly for the diagnostic test, okay, so here what they're trying to tell is like, say for example, the patient is coming to identify what is the problem. Okay, what is the problem? So they come to know by with the help of lab work, like some pathological laboratory work, or with the imaging, or with the help of intervention radiology help. Okay, they use some method. Okay, they use some method to identify some problem. Okay, that is what called diagnostic services. For that, the diagnostic condition, whichever the condition is being chiefly proved, or whichever is the problem is mainly responsible for the test, that need to be coded as the primary diagnosis. Okay, that is what they're trying to tell. If anything is not proved, will be ending up with the Z01.89. So I need to check for the diagnostic condition. Okay, so for to identify which disease, what disease it is, I need to go for different level of tests or different types of tests, blood test, lab work, or imaging work, or like interventional radiology, or therapeutic also they may do, physiotherapy also they may encounter. Okay, whatever it is, what is the main reason for this diagnostic test? That will be considered as the first listed diagnosis, or if any condition is proved, that will be considered as the first list of condition. Say for example, the patient is coming as a diabetes patient, then they wanted to check for the level of glucose, and they will be checking whatever the other signs and symptoms. Okay, this all will be there. Now the reason why they came for the blood test, because he is a diabetic patient. Okay, so that is the condition we need to consider as a first listed diagnosis. Same for the therapeutic services also. One good example here is dialysis. The dialysis is something that it is considered as a therapeutic service. So when the patient is coming for the therapeutic service, that will be considered as a primary or first listed diagnosis. One more good example we can tell, that is like a patient is coming for the cancer, and a cancer patient is treated with the chemotherapy or radiation therapy. Okay, now the principal diagnosis here, what I supposed to code. Okay, and the principal diagnosis, what I'm supposed to code here is like Z51 series I'm supposed to code. Okay, but what our guideline says, therapeutic service should be coded as a primary, which means cancer should have been coded primary. That is the main rule, right? That is what this guideline says here. Okay. So he has come for the cancer, but he is treated with the chemotherapy. Our 21st guidelines related to the chemotherapy or radiation therapy, what it says, if the condition is treated with the chemotherapy or immunization therapy or radiation therapy, the Z51 series should be coded primary. Followed by that, we need to code the whichever condition it is. Okay, whichever the therapeutic services or whichever condition it is need to be coded second. But here, both are contrasting each other, right? Here, even though he is treating for the cancer, I'm coding the cancer as a first, not a treatment, even though it is a therapeutic service. Okay, so that is a main difference. One exception, that is, they added that in the one exception for oncological patient receiving chemotherapy, radiation therapy, and the immunization therapy. First listed appropriate Z51. Here, the weightage is coming for the chapter guidelines more than the general guidelines or outpatient guidelines. It is coming for the chapter specific guidelines, which we are using Z51. Then preoperative evaluation. Okay, so when it comes for the preoperative evaluation, remember Z01 will be the primary code. The screening, preoperative, and the conditions if it is not proved. In this scenario and all, if you remember in the 21st chapter, the first section, Z0000 section. Okay, in the first section, the categories of codes which will be applicable for this unproved condition or uncertain diagnosis or condition which has come for but it is not proved. And tertiary, if you see for preoperative evaluations, okay, especially this preoperative evaluation, they'll be using the Z01.818, 810, 810 for the cardiac related surgeries, 811 for respiratory related surgeries, and 812 is there for other conditions, and 818 is for other specific condition, and 819 for unspecified conditions. Usually that 9 will not use most of the time. 818 will be very often used. Then second highest used is like Z01.810. Okay, so preoperative will become the primary diagnosis. Then ambulatory surgery. Here, ambulatory surgery, if you see, especially this ambulatory surgery means, as I'm telling you previously also, it is going to be the same day surgery. Okay, it is going to be a same day surgery. Here, when the coding for outpatient surgical procedure, code a diagnosis for which surgery was performed, which we call it as preoperative conditions and postoperative conditions. Okay, so which is preoperative diagnosis and postoperative diagnosis. During the preoperative, I may have the kidney stone. Okay, then after the operation, they may remove the kidney stone. What is my diagnosis now? Okay, what is my diagnosis? Always in the surgery, preoperative and postoperative going to be the same. So it is better to use always the what is the reason for the, or what is the primary reason or principal reason for the surgery should be coded as a IC. Then routine prenatal visit. Here, just to indicate, I will be using Z34 series code. Okay, so if the, especially in the pregnancy report, okay, if you see in the diagnostic radiology, this 76815, 76801, 802, they're less than 14 weeks, greater than 14 weeks. For these particular conditions, these particular procedures, where the patient may come for the follow-up, regular follow-up, every 3 months or 6 months, they may come. And there won't be any complication is proved. The patient is normal. So to indicate it is a supervision of normal pregnancy, we will be using the code that is Z34. Okay, so same guidelines we can refer in the chapter 15. Okay, pregnancy chapter is there. No, there also these guidelines will be there, where Z34 will be used for supervision of normal pregnancy, first trimester, second trimester, third trimester, and specific trimester. 4 set of codes we have. Then medical exam with abnormal findings. Here, so when the documentation is finally proved with any abnormal findings, we are supposed to use Z000 and Z0010, which means encounter for medical exam with abnormal findings. Okay, that will be indicated as the primary diagnosis or first listed diagnosis, then followed by whatever the abnormal findings that should be coded. Then routine health screening, very simple. When the patient is coming for the screening, please code the screening as a primary. Okay, so there are two categories of screening codes. One is Z11 to Z13, that is one set of which is indicating the screening for the diseases. Z36, which is the screening for the pregnancy report. Okay, so routine health screening is which we need to code as the primary diagnosis. Okay, then this is something, a difference which we need to know about inpatient and outpatient. Diagnosis terminologies here. First listed diagnosis or primary diagnosis we can tell. Here, principal diagnosis. These terms are little important. Since you are CCS person, So that is what I'm trying to tell. When you learn the CCS, we learn both inpatient and outpatient mostly. Okay, and here you learn everything additionally only. So the comparison is very, very important. If you know the comparison, this is something called associated study. Even though I'm taken all the guidelines, what is finally it is telling to you? What is the major difference between the primary and the inpatient and the outpatient? What is the difference? That is what we are seeing here. Okay, so diagnosis terminologies, first list of diagnosis, principal diagnosis. Here, uncertain or ruled out diagnosis, do not code, use signs and symptom, code as documented, rule out of appendicitis, code appendicitis. Symptom coding, encouraged if no confirmed diagnosis, limited diagnosis is preferred. Here in inpatient, I cannot go for the signs and symptom. I already told you. Okay, so maybe additional diagnosis we can consider, but we cannot consider for as a principal diagnosis. By keeping the signs and symptom, I cannot take you for the surgery. Okay, that is what I'm trying to tell you. Z code frequency, frequently and appropriate. Yes, whenever, wherever is required, we need to use a Z code. Sometimes they become the primary code, sometimes they become the secondary code. Okay, if you see aftercare, screening, pre-operative, and screening for neonatal, these are all areas Z series can be coded as a primary. But when it comes for the inpatient, it is infrequent. So we have seen one example which is like Z53, and one more is like Z91, where they are not carried. Okay, they have planned for the what is it? They have planned for the procedure, but they are not able to carry out the procedure. In that situation, we'll be using two set of code. Yes, one more set of code also is there, but it is not very often used in the IPTNC. Then complete clinical picture, all coexisting conditions required. Yes, what are the conditions are available in the impression, everything till 12 diagnosis we can code in the outpatient. Some projects they ask us to code four, less the like four is sufficient, but most of the project they may ask us to code all diagnosis. But when it comes for the inpatient, here principal plus secondary conditions based on the admission reason. Okay, only the principal and secondary conditions are very, very mandatory. Application of the guideline, section 1 and section 4 applies for the outpatient, where in inpatient, section 1, 2, 3 will be applied. Okay, so this is what the 4 section of the ICD, which is applicable for both the inpatient and the outpatient. Yes, Buna, we are good?
Yes, sir.
Okay, so I have some examples for the freshers. Okay, so some examples I added. I don't think so it is going to be very mandatory. It is going to use for you. Okay, so it is like how we are going to code. If the patient has come for, see one example, like two example we'll discuss. One scenario, patient has come for chopping in the kitchen, mobile home for the local food bag, Thanksgiving dinner. Joni Dio lacerated his right thumb using the injury. Now I'm going to code the laceration as a primary, then external cause code. Okay, what happened, then place of occurrence, then activity. Here I don't think so status is required, because the military or is the civilization is not very mandatory here, because it is not documented that also. So we can just go with the occurrence and the activity and the external cause code. Very importantly, injury related code as a primary diagnosis. Same second thing, if you see, fall from the stairs with the injury. So fall from the stairs with the injury. Here, Jane and John, they was shopping in the mall, shopping at the mall the day after the Thanksgiving. While rushing for the newest iPhone, John fell down the stairs, sustained minor abrasions to his right elbow. Now, abrasion should be coded, followed by the external cause, fall on the stairs, then place of occurrence, where it happened in the shopping mall. Okay, here I don't want to address about the, what is that? I don't want to address, even I don't think so. Yes, it is not required. The status is not required here. If it is documented, if it is given in the documentation, we can put, otherwise it is not required. But activity, yes, we can code. While rushing for the newest iPhone, that is become the activity. Okay, that should be coded, which will comes in the Y series. Okay, place of occurrence they given as a shopping mall, but activities also should be given here. Okay, that comes in the 9.3 series. So this all the chapter specific guidelines for both inpatient and outpatient. Okay, just give me a minute.
Okay.